So you might have some loved ones, or you might have friends who have loved ones who will randomly die without any known cause. And this happens frequently, not just during pandemics, but this happens. And it sucks, and we won't know why this happens. And one of those things that can cause sudden death are aneurysms. Now, what is an aneurysm exactly? So think of it as, and brain aneurysms are a common one, but think of it as a ballooning of an artery, and it's caused by the weakening of the arterial or the artery wall. So basically, your blood vessels are under pressure, and if the blood vessels become weakened in some way, and one way to accomplish that is through repeated inflammation. When that happens, then you have the possibility of a ballooning to happen with those arteries, and that entire process can easily lead to a rupturing of that artery, and in of itself it can be very damaging to have a ballooning of an artery. So that is why aneurysms are so sudden and so abrupt and really can just come out of nowhere. So here, what I really want to go over that I wasn't even considering I wasn't even considering this happening, but since COVID-19 can elicit strong inflammatory responses, and even if people are asymptomatic or don't show outward symptoms, there might still be some inflammatory dysregulation. We might need to be concerned about random aneurysms that are happening. So this is an old paper. It came out in early March, and it was not peer-reviewed. So keep in mind, this is not a peer-reviewed paper. This is just a case study where I wouldn't even call it so much of a study. This person had died very abruptly. So, but this person had an aneurysm not long after being admitted to the hospital and died. So what I want to do is go over this paper, because you might have loved ones who have loved ones that will suddenly die, and we might be forced to admit that COVID-19 probably played a role in those aneurysms, or at least increase the likelihood for those aneurysms to take place and or be more severe. So this is just the reality of all diseases, really, all diseases that take advantage of our comorbidities. They will end up pushing us closer to death. So even if the initial contraction of a virus doesn't kill us, and even if it's asymptomatic, we really need to be concerned about how it can push us closer to death, and how our other comorbidities might be exacerbated by COVID-19. And this is something that, I have been screaming about it to a degree, but there is it is very possible that I might have underplayed the severity of this. So I want to go over this paper. It's called Misfortune Never Comes Singly. It's the first case of COVID-19 with the rupture of a thoracic aortic aneurysm. So basically, this person had an aneurysm in his thorax. So let's look this up just so that I'm not, spouting nonsense. So, this, I don't want to get up an image that has a copyright on it, because I don't think that's ethical. Let me look up Wikipedia just to see if, okay, good. So this is an aneurysm that takes place in the thorax. And a thoracic aortic aneurysm is the ballooning of the upper aspect of the aorta. So you can see here this aorta, and remember the aorta would be oh wait, is it coming? Yeah, it's coming right out of the heart. So the heart is pumping this pretty much directly out of it. And here you can see if you have a ballooning here, then this is probably the structure of this has been compromised severely. So, and this is just one type of aneurysm. There are many types of aneurysms, but we can pretty much by now safely assume that COVID-19 is probably going to create a heightened risk for aneurysms in all parts of the body. Granted, the thoracic, I don't know, I can't pronounce it right. The thoracic aortic aneurysms are probably one of the most deadly. I wouldn't be able to tell you. I'm not in the medical field at all. I just want you to be aware that this is something that had happened. So, this person, I'll just go down through it. So here's the abstract. SARS-CoV-2 is a newly discovered virus, and it's leading to COVID-19, leading COVID-19 a global threat nowadays. So, and keep in mind, these people are from China, so their ability to write with absolute fidelity is not there. But we can be very thankful that they decided to use the lingua franca, or English, for writing this, because this is really good information for all of us to read. So here's the case presentation. So the first case of a patient with thoracic aortic aneurysm, or TAA. This is the first case where someone with this aneurysm that became infected with SARS-CoV-2, and this was reported here. The patient died suddenly from a ruptured aorta 19 hours after hospital admission. So here's the conclusion. COVID-19 patients with the TAA, or the thoracic aortic aneurysm, these people should attract the highest vigilance, as COVID-19 might expedite or speed up the process of TAA rupture through cytokine storm syndrome. So remember, these cytokines, or at least the pro-inflammatory cytokines, frequently they will weaken tissues. And one of the benefits of weakening tissues is that it can allow white blood cells to penetrate much more easily. When things are very inflamed, that allows these white blood cells to really squeeze in between the other epithelial cells, or the other cells in general, in order to attack whatever it wants to attack. So that could be one of the reasons. So here's the conclusion. COVID-19 patients, and here's the background. So the cases of an initially unidentified viral pneumonia was first reported in Wuhan, Hubei province, China, in December 2019. A novel coronavirus, SARS-CoV-2, has since been identified as the etiological agent, and etiology is, these are the causing agents, and the associated viral pneumonia has been named coronavirus disease 2019, or COVID-19. This viral outbreak spread throughout China and to multiple other countries within 1 month of the first of the first confirmed case on January 30th, 2020, the World Health Organization identified COVID-19 as a public health emergency of international concern. So multiple reports have described COVID-19 clinical symptoms like a dry cough, fever, dyspnea, and fatigue. And as a reminder, dyspnea is difficult or labored breathing. So if you are having a hard time breathing, that would be dyspnea. This has been reported, or it has been reported, that COVID-19 patients with underlying comorbidities, hypertension, diabetes mellitus, and cardiovascular disease, these people are at a greater risk of SARS and death. So because SARS-CoV-2 is a newly discovered virus, we have limited knowledge about the associated disease. So in the context of an ongoing outbreak, here we report the case of a 68-year-old man, so keep in mind this was an older gentleman. We report the case of a 68-year-old man with no distinctive clinical features. So this is something that we really need to be aware of, is that this person did not have distinctive clinical features. This person was, for all intents and purposes, just a healthy 68-year-old individual, you know, probably with decades of life still ahead of him. But with the COVID-19 confirmed by RT-PCR, or this is testing for the RNA of the virus, who had comorbidities and died of rupture TAA within 19 hours of hospital admission. So we hope that by rapidly sharing this case report, we can draw attention to the potential lethality of COVID-19 plus the thoracic aneurysm. So, and, you know, he did have comorbidities, but we all have comorbidities, right? We all, especially once you're getting up to that age, pretty much everyone is going to have something that is wrong with them, right? We age for a reason. So we shouldn't look at comorbidities as a death sentence. We should look at it as just a natural part of existing in this world. So we really should work around them when possible, but it is sometimes we just have comorbidities, and it just happens with aging. Doesn't mean that the life is worth any less. Right. Anyways, we hope that by rapidly sharing this case report, we can draw attention. So here's the case presentation. At 9 o'clock on February 15th, 2020, a 68-year-old man consulted an emergency physician in the first affiliate hospital of Zhengzhou University for a 10-day abdominalgia. And I think this is pain in the abdomen, so let me... Okay, so it's technically an obsolete term, and remember these aren't native English speakers, so they might be using obsolete terms as well. They might have been taught using a different dictionary, right? So, but it's abdominal pain, and a 6-day cough accompanied by objective fever. So the highest auxiliary temperature was 39.1 degrees Celsius. He presented with a mask and disclosed that he had come from Qingyang, Henan Province, China, which is the most severely COVID-19 affected city in the Henan Province. However, our patient did not admit having traveled to Hubei Province or having direct contact with people who came from Hubei Province, and denied having any history of hypertension, diabetes mellitus, cardiovascular disease, tuberculosis, or hypertriglyceridemia. So, for all intents and purposes, they said he had a comorbidity, and that comorbidity was the aneurysm. But he tended to be healthy in other aspects of his life. And he did say that he did smoke most of his life, but he had always been healthy. So, physical, and remember, it's not as if his lungs were the issue here. Granted, the smoking might have contributed in some way, but in general, it looks like he was going to be fine and okay. So A physical examination found an auxiliary temperature of 38.5 degrees. So auxiliary, I would believe, would be, close to your extremities, and the pulse of 106 beats per minute, which is elevated. I think that's tachy. There's a Greek word for that, and a respiratory rate of 27 breaths per minute. So that is slow, I believe. So blood pressure was 159/85 milligrams of mercury, and oxygen saturation of 98% when the patient was receiving 3 liters per minute of oxygen through nasal prongs. So the oxygen saturation value dropped below 92 when he was breathing ambient air. So, yeah, apparently, I guess I spoke out of turn. He did show clinical symptoms, that is for sure. But it sounds like he really only needed some supplemental oxygen. It doesn't sound like he was in critical or serious condition. So, considering that the patient had come from the most severely infected area in Henan province, the nasopharyngeal swab specimens were collected as routine, and pathogens including influenza A and B were tested for. Then, this patient was isolated in the emergency ward. Long auscultation revealed diminished sounds and moist rales. So I'm not exactly familiar with what lung auscultation is. So I like doing Wikipedia so that these respiratory sounds refer to the specific sounds generated by the movement of air through the respiratory system, and these may be easily audible or identified through auscultation. Oh, so this is when they take the stethoscope. Yeah, okay. Is listening to the internal sounds of the body, usually using a stethoscope. So they used the stethoscope on the lungs, and it revealed diminished sounds and moist rales. So I'm not familiar with what. So these are small, clicking, bubbling, or rattling sounds in the lungs. So they are heard when a person breathes in or inhales, and they are believed to occur when air opens closed air spaces. Rales can be further described as moist, dry, fine, or coursed. So it sounds like clicking or bubbling that is taking place whenever they breathe. So I would assume that that is not good. So the lab results were returned as negative for influenza A and B at 9:28, while the nasopharyngeal swabs tested positive for COVID-19 by reverse transcriptase PCR at 16:40 the same day. The patient was immediately transferred to the isolation ward. So the patient complained of a 10-day history of consistent abdominal pain, which was accompanied by constipation. He did not report nausea and was not vomiting, but he could not clearly describe the precise position or character of the abdominal pain. He reported that he had malaise or just general feeling of feeling unwell, right, with breathing, and that he had sometimes coughed up white mucus during the past 4 days. Vital signs showed fever, tachypnea, which I believe is the accelerated heart rate. Tachypnea means the abnormal rapid breathing. So tachycardia, so this is the rapid heartbeat and raised blood pressure. So at 19:27, and that is, gosh, can't do math right now, 7:27, the chest computed tomography or CT scans, and the contrast-enhanced CT detected bronchitis, emphysema, and thoracic aorta aneurysm. But no particular abnormality was observed in the abdomen. CT scans, imaging, and this is interesting that in the abdomen there didn't seem to be anything wrong. So although his pain was in the abdomen, it might have been associated with what was happening in his heart. Continuing, CT scan imaging identified diminished transparency of lung and fuzzy margins consistent with COVID-19, but no specific manifestation. So think these are the opacities that are in the lungs. They found that in the CT scans. As there's no specific treatment for COVID-19 therapy, um, therapy mainly consisted of symptom control to deal with the fever. The patient received, that's a lot, 900 milligrams of aspirin lysine by intramuscular injection once. He also received 300 milligrams of doxycycline once, and let's look up what doxycycline is. Is a xanthine derivative used in the treatment of asthma, so this would be something to help treat his breathing, once by intravenous drip to treat his bronchitis, and expectorant consisting of 90 milligrams of ambroxol, so expectorants are things that will help get the mucus out, and this is given once by intravenous drip to manage his white mucus. And keep in mind, they did all these things once, and that's probably associated with how quickly and how suddenly he died. So I want to look up the typical dosage for aspirin. So typical aspirin dosage. Wow, there's a large range. So between 50 milligrams to 6,000 milligrams daily, depending on use. So and 325 milligrams for people on doctor-directed aspirin regimen. So 900 milligrams, yeah, that's that's high, but it seems to still be an order of magnitude within normal range. So focus, come on. There we go. So he also received 300 continuing. So one of my concerns was perhaps the aspirin, I don't know if that might have actually increased the risk of, what's it called, the aneurysm rupturing, but I don't believe it would, not at those dosages. Granted, I'm not a pharmacist nor am I a doctor, so do not quote me on that. So sodium nitroprusside was pumped into the drip to control the high blood pressure. Lopinavir and ritonavir tablets were given twice a day to help control virus. Blood tests, blood cell count, and serum chemical tests displayed mild erythropenia, leukocytosis, and thrombocytosis. So what are all of these things? So, cancel. Erythropenia would be too low of red blood cells. So a decrease in the number of erythrocytes associated with anemia. So this person appears to be anemic. Leukocytosis, which would deal with the leukocytes, so it's an increase in the number of leukocytes, or the number of white blood cells in the blood, especially during an infection, so that would indicate that there's an infection going on. And thrombocytosis, which I believe would be elevated thrombi. So it's a condition where there's an excessive number of platelets in the blood, so this person was producing a lot of platelets. So CT imaging indicated pneumonia, and clinical symptoms and blood counting suggested that bacterial pneumonia might also be present. So you might have seen people make fun of, and you might have, where they make fun of the administration of antibiotics for a viral infection. Now, frequently, opportunistic pathogens, such as bacteria, will take over damaged tissues that have been damaged from viruses and from the inflammatory response due to those virus infections. And so the administration of antibiotics might actually be, or I shouldn't say might actually be, are frequently required because you need to get bacterial infections under control as well. So anyways, based on these findings, 400 milligrams of moxifloxacin once per day and 3 grams of sulperazone every 8 hours were administered. And our patient was consistently supplied with oxygen by nasal cannula at 3 liters per minute to maintain an oxygen saturation of around 98%. The measurement of hepatic function was revealed an albumin level of this, globulin level of this, and a cholinesterase level of that. So I do not know what the normal levels for these. So albumin is a protein that you produce. So let's look up albumin level. So here, let's say that the normal range is 3.4 to 5.4 grams per deciliter. So if we go back here, 25.3 grams per liter, which would be equivalent to 2.5 grams per deciliter. Wait. Deciliter? Oh, wait. No, I think, let's look this up. 25.3 grams per liter. Grams per deciliter. It might be, okay, yeah, so 2.53. So that is normal, right? So this is, or no, that's a little low. So that is low amount of albumin, and then the globulin level was 43.4 grams. Low globulin levels can be a sign of liver or kidney disease, and high levels may indicate infection, inflammatory, or immune disease. So let's look up what is the normal globulin levels. So serum globulin, 2 to 3 grams per deciliter is normal, and here he's at 4.34 grams per deciliter. So this is grams per liter, but 43 grams per liter, but it'll be 4.3 grams per deciliter. So it looks like he has an active infection, according to his globulin levels, and his cholinesterase level of 3 Ku per L. I don't even know what that means. So we'll just keep on. Oh, so this would be a measurement of activity. So this is 3 kilo units per liter, if I am reading this correctly. So a unit would be a standard unit of a reaction rate. So cholinesterase is an enzyme that I believe would either break down the choline ester of some form, but I wouldn't be able to tell you. So let's look up cholinesterase level, and so this is serum cholinesterase is a blood test that looks at levels of 2 substances that help the nervous system work properly. So they are called acetylcholinesterase and pseudocholinesterase, and your nerves need these substances to send signals. So let's look up normal, and I would assume if these are out of whack, then there's a problem. So normal normal levels range between 8 and 18 units per milliliter, or 8 and 18 kilounits per liter. So this is at 3 kilounits per liter, so this would be low. Yes, so he had low for all of them. For all those, he's a little bit low. Here, he's definitely very low. So at close to midnight, the patient's procalcitonin levels increased to 1.34 nanograms per milliliter, and so the reference range is 0 to 0.46 nanograms per milliliter. So procalcitonin, I believe, would be damage, and often it's in response to bacterial infections, but also in response to tissue injury. So the level of procalcitonin in the blood can increase significantly in systemic bacterial infections and sepsis. So this increase in procalcitonin would mean that he has an ongoing infection. The C-reactive protein levels increase to this, which is way, way, way above normal. And if I remember correctly, the CRPs can be an indicator of inflammation. So this would probably mean that he is in a pro-inflammatory state. So yeah, the concentrations rise in response to inflammation. So and interleukin, this is one of the cytokines. So interleukin 6 levels increase to this in the reference, and that is much higher than what it should be at normally. So the patient was under continuous electrocardiographic or ECG monitoring after being admitted to the isolation ward. This patient disclosed that he felt better after supportive treatment given by his doctors, that this person was feeling better. Whatever they were doing was alleviating symptoms and improving his quality of life at the time. So on February 16th at 3:10, the patient's condition rapidly worsened. The monitor alarmed that the blood pressure and heart rate of the patient could not be detected. The patient lost consciousness and had no response to his doctor's calls, and the patient had no bilateral pupillary light reflex and carotid artery pulse. So shine a light in the eye, absolutely no, there was nothing happening with the eye, so this person pretty much died instantaneously. So in this emergency, doctors placed the patient in a prostration position without a pillow and immediately performed cardiopulmonary resuscitation, or CPR. Adrenaline was given every 3 minutes by intravenous injection, and 180 milligrams of dopamine was pumped in to increase heart rate and blood pressure. So he was definitely, I don't know if he was technically dead at this point, probably not. So they're trying to get the blood flowing again. And intubation was operated by the doctors wearing appropriate protective equipment. An ultrasound technician and vascular surgeon were invited for consultation. And the chest ultrasound at our patient's bedside presented extensive pleural effusion. So what is pleural effusion? So it's excess fluid that accumulates in the pleural cavity, the fluid-filled space that surrounds the lungs. So this excess fluid can impair breathing. So this extra fluid was filling his lungs, and which did not show up by the CT scan. And the doctors reached an agreement that the patient's aorta had ruptured. So this, the ultrasound, I assume they had to give an ultrasound because there'd be no way that you could do a CT scan on this person, and they said this pleural effusion did not exist when they did the original CT scan, but now there is this pleural effusion. So I believe they realized that the only thing that could have caused that was the patient's aorta rupturing. So the patient's vital signs did not recover despite the rescue measures, and a flat line was seen in the EGC monitor at 4:12 on February 16th, within 19 hours of hospital admission. The patient was pronounced dead. God, that sucks. So keep on going. So nasopharyngeal swab specimens were collected using synthetic fiber swabs by a nurse wearing appropriate protective equipment, and the swabs were placed in a virus collection tube containing 3.5 milliliters of transport medium, and the collected specimens were tested immediately after collection by reverse real-time PCR. The whole specimen collection procedure followed the published guidelines. So COVID-19 in our elderly patients. patients. So the clinical manifestations of the 68-year-old man began abruptly. From the onset of abdominalgia to final death, the entire illness course was 10 days. The contrast-enhanced CT data were not suggestive of gastrointestinal disease. Given that there were no specific gastrointestinal disease by CT scan imaging, it seems likely that our patient's abdominal discomfort was caused by COVID-19. So 4 days after the onset of symptoms, he started to cough up white mucus. Moreover, the chest CT plain scan presented diminished transparency of the lung, fuzzy margins, fibrous stripes, and patchy shadows with no clear ground glass opacification. So his scans had something on it, but it was not clear ground glass opacification. So that's interesting. So blood counts were suggestive of leukocytosis, neutrophilia, and lymphopenia. The patient tested positive for coronavirus by RT-PCR, and these features suggest that this elderly man suffered COVID-19 combining with bacterial pneumonia. So based on this clinical experience, COVID-19 diagnosis might be missed as bacterial pneumonia and has more visible clinical features than COVID-19. Nevertheless, this case indicated that cytokine storm syndrome was the straw that broke the camel's back, resulting in the sudden death of our COVID-19 patient. Pneumonia sucks. And one thing that we are going to have to worry about is, as we get infected with the virus, we are going to have weakened defenses temporarily against other comorbidities. So let us not, there's a great risk that we are going to be misdiagnosing deaths from other causes or I should say we're going to be misdiagnosing COVID-19 related deaths as completely unrelated bacterial infections or what have you. So let's not fall into that trap. Anyways, COVID-19 and thoracic aorta aneurysm. So the patient's blood pressure was 159 over 85 milligrams of mercury on admission, and the chest contrast enhanced CT found the thoracic aorta aneurysm, and hypertension is the leading cause of aortic aneurysm, and this patient died within 19 hours of admission to the hospital, and the entire disease course lasted 10 days. So this person had symptoms for 10 days, goes into the hospital after a while, and then dies pretty much immediately after the fact. In this case, COVID-19 likely expedited an underlying aortic aneurysm. So COVID-19 was likely the cause that made this aneurysm burst faster. So this likely resulted from a disbalance of angiotensin II and angiotensin converting enzyme 2. So there is the possibility that the hormones, angiotensin, these get differentially regulated in response to the virus infections. And so it's possible that by changing the relative concentrations of angiotensin 2 and angiotensin converting enzyme 2, that could have helped cause the aneurysm to become more severe, probably by increasing blood pressure somewhat. So some reports have suggested that angiotensin 2 can induce these aortic aneurysm ruptures, and that the angiotensin converting enzyme 2, or the ACE2, inhibits angiotensin 2 induced abdominal aortic aneurysms. So SARS-CoV-2 infected patients, by binding to the ACE2 of humans, this would lead to an exhaustion of ACE2. So the virus itself would be blocking ACE2 converting enzyme, angiotensin converting enzyme 2. It would prevent that from functioning correctly. So that might be something that would help, that would theoretically stop the conversion of angiotensin II. Regardless, I wouldn't be able to recreate um, all the biomechanics of that in my head right now. So given the rapid death of our COVID-19 patient with thoracic aortic aneurysm, we hypothesized that COVID-19 might expedite the process of TAA. Nevertheless, more convincing clinical and laboratory data are needed to confirm this hypothesis. So COVID and the liver function damage. So this is, remember when I looked up these proteins earlier. So the albumin, the globulin, and globulin results were suggestive of hepatic or liver damage. So the low albumin to globulin ratio also attracted their attention. So in China, this low albumin to globulin ratio is typically caused by hepatitis B viral infection. So yet this patient was free of hepatitis B and C. So this might not mean a lot to a lot of you, but in China, or I should say, those who have Han Chinese heritage, they have a mutation in their genes, and it's not even a mutation that is a part of a protein. It is one of the regulatory sequences in DNA that promoters can bind to. So one of these, or how to phrase it, so that it is a promoter that other proteins can bind to. And so these, the Han Chinese have a mutation that makes it so that if they contract hepatitis B, then the virus can actually cause a lot more damage to the liver than other people groups would experience normally on average. And so in China, this is actually something that they care significantly about. They pay a lot of attention to liver diseases because they are at a higher risk of hepatitis-related chronic illnesses. So this finding is consistent with the notion that COVID-19 also attacks the liver, which is consistent with previous reports. So here they're saying that the liver damage was not from hepatitis, which is why they looked for it. It was actually from COVID-19. So here's the conclusion. Here we report the clinical features of COVID-19 in an elderly man. You know, age is subjective, right? I mean, if he was still healthy, should have lived longer. This was not distinctive, especially given that the patient had primary lung disease. Okay, so he did have lung disease, probably from all the smoking that he did throughout his life. COVID-19 patients with the thoracic aortic aneurysm should attract the highest vigilance, as COVID-19 might expedite the process of TAA rupture, leading to rapid death with little or no warning signs. COVID-19 could progress rapidly to cause cytokine storm syndrome, worsening the prognosis. Hepatic damage was observed in this COVID-19 patient who had no hepatic disease history. In response to this ongoing public health emergency, we have collected and summarized the data associated with this cause so that they can be shared with the international community, and we would like to take this opportunity to kindly encourage all clinicians, scientists, and public health professionals to openly share clinical and research data in as timely a manner as possible, thereby helping to combat this viral threat. I feel like this could definitely be confirmation bias. This can definitely be seeing patterns where they don't actually exist. But my Facebook page has been, there have been a few more posts about random relatives suddenly dying, and I really don't want to read too much into it. But I am concerned greatly, actually, that COVID-19 is exaggerating the effects of other comorbidities and causing disease progression and expediting that disease progression when really these people had more time to live. They had more time in them. So, yes, maybe it was comorbidities, but people with comorbidities deserve to exist in society a little bit longer. And maybe people with comorbidities might be given the chance to heal their comorbidities down the road. They shouldn't just be tossed aside. So, I had a relative recently. wasn't close to him at all, but I had a relative who had died very recently. He was mid-50s, so not ancient. It was an aneurysm in a location that probably had significant undiagnosed coronavirus cases. So, and he was just found dead in his yard. Freaking nightmare for his children to just, I don't remember who found him. He was found right away, but just what a nightmare that would be to lose one of your close relatives so suddenly. And yeah, I wish that we had gotten on this earlier to put my mind at ease, because now I thought that this was going to happen, but I wasn't sure. But COVID-19 makes people vulnerable. It makes you vulnerable. It makes you easier to kill, especially right after you recover. And I don't know if they are going to do a postmortem diagnosis to see whether or not that was the case, but I was concerned months ago that I would hear about people dying more often than I would normally hear it. That they would just start dying faster, and it would almost come like a thief in the night, or thief in the night, where it'd just be sudden, immediate, and no one saw it coming. And I'm already seeing that. We're still at the very beginning. We're still at the very beginning of dealing with COVID-19, and we're still at the very beginning of dealing with this disease and dealing with the long-term risks and the long-term health consequences. And these are things that I mentioned, that I was talking about at the beginning of this pandemic, but it wasn't something that I am still mentally prepared for. I am still not mentally prepared for how many people are just going to die within the next decade that would have normally lived 2-3 more decades. I'm afraid to start seeing those numbers actually show themselves. And then we run the risk, right, of never actually getting immunity. Yeah, we might have antibodies, but those antibodies themselves might be damaging to our own systems. Gosh. And, you know, for instance, if we make antibodies against the spike protein in the receptor binding domain, then we might make anti-idiopathic receptors to those antibodies, which might still block even more ACE2 receptors. Man, all this freaking biology. Okay, so yeah, that's just what I wanted to talk about right now, was there are people dying before their time, long before their time, and it's starting to hit a little bit closer to home than it used to. And yeah, we'll see what ends up happening. I hope I'm wrong. You know, you gotta prepare for the worst, right? Prepare for the worst, hope for the best, and that's what I'm doing with these videos. I'm preparing myself, and whoever the hell wants to listen, I'm gonna prepare y'all for what I think is the worst. Granted, I could be wrong. It could be even worse than what I thought. That just sucks. So with that, have a good one. Stay safe, stay healthy, get sunshine, and yeah, enjoy your weekend.